Okay. Hi, everybody, and thank you for bearing with us as we work out the electronics of this, as usual. Thank you for joining us. I'm Mark Schwartz, and some of you already know, and nice to see you again. I want to talk to you about intimacy and intimacy disorder, and just a brief introduction, which is that some of you know that I started my work many years ago, I won't count how many, with John Money at Johns Hopkins, and we began working with people who had deviant forms of sexual arousal. Some were into fetishes, some were into unusual forms of arousal, some molested children. And I had this penetrating curiosity about what it is that arouses a person in a healthy way or an unhealthy way. And they seem to be related. You've got to understand this concept. Like, for example, why does a person marry an alcoholic when their parents were alcoholic? Why is there such thing as repetition and reenactment? Why does someone do the same thing over and over again in a self-destructive way in relationships? I became infinitely curious about this, and nothing made any logical sense to me. From there, I went to Masters in Johnson, and I worked with couples. And when I worked with couples, what I found was that we could help relationships and marriages, but that our ability to help troubled marriages was actually quite limited. And so I became interested in this thing called intimacy disorder, where people would get close together, but they have a hard time connecting and bonding in some way. And so one person would be sort of clinging to the other with the hopes of somehow trying to get close to them. The other person would be avoidant. We call those merger-seeker kind of relationships. And the more energy the person put into merging, there would be a certain amount of energy with the person trying to get away from in some way. So what is it that sets these patterns up where people merge and they seek and affect one another in this way? Well, to look for the answers to this, I went back to my training. And in my original training, I worked at Johns Hopkins, and there I met John Bowlby, and Mary Ainsworth was there at the time. And we were interested in the attachment system. And the attachment research was really quite important in beginning to understand intimacy in relationships. And so what we did is, if you remember that early research on attachment, there was the infant in close contact with the mother, and then the mother would leave the room and come back, and that was called the attachment in the laboratory in the strange situation. And as those research got followed up, they found that these were incredibly predictive, that within the first 10 years of life, you could predict a high degree of the variance based upon what you saw in the first 18 months in the interaction with the infant and the mother. It was really remarkable, unbelievable. And so these patterns that got set up were avoidant attachments, where whenever there was an anxiety, the person would move away from. There was preoccupied attachment at the time, anxious attachment, where when anxious, the person would move towards. And more it got understood that these attachment systems were in the brain and had this evolutionary significance that Bowlby talked about, that whenever there's danger, it would be in the organism's best interest to be able to hold on to and to cling. So why is it that some children would move away from their parents when they were anxious? It seemed against evolution. Anyway, so it was pretty remarkable. And so what we began to recognize in these intimacy disorders was that these were long-standing patterns that got laid down in the brain, and that various things that happen in your childhood would begin to affect it. Now it's some 20, 30 years later, and the question is, where have we come? There's two books that have influenced me probably more than any other. One of them is Schwartz's book called The Development of the Person. If you haven't seen this book, next to Bowlby, I thought it was the most important book ever written. Unbelievable research, 30 years in length, where Schwartz looked at these children and their attachment patterns every year for 30 years in a longitudinal way. And then Mary Main's work out of Berkeley, where she devised the adult attachment interview, which was a whole different way of beginning to think about intimacy in adults, which I'll be talking about in some depth. And then the third piece of this came from me from Patricia Crittenden's work with assessing adult attachment. And I'll be talking about some of her work because she worked with Mary Ainsworth also with Mary Main, and the three of them I think have contributed the most to our understanding of the field. So that's the background of this. Now I want to apply this to two things. One is our understanding of intimacy between any two people and intimacy disorder. And more important, I think, for our work is trying to ask ourselves, if people have disorganized attachment based upon the early years of their life, then is there anything we can do to be able to promote secure attachment? And my hypothesis over the years has been that since I work a lot with trauma survivors and work with addicts, that it was important to get the addiction under control as the first stage of treatment, or the depression or the anxiety. And then the second stage was to treat the trauma or the post-traumatic stress or the complex trauma. And then the third was to begin to repair the attachment system so that people could turn to other humans for comfort rather than turning to a substance or else being totally alone. And much of the work that Schwartz published really supports this pattern of understanding that probably more than anything else predictive of adult psychopathology is childhood trauma. And the early attachment pattern set up the response to childhood trauma. So you can think of it in this way. Cloninger and others have talked about children come into the world with various kinds of dispositions, and in these dispositions they're genetically hardwired in one direction or another. And then the first 18 months comes in, and the infant-parent interaction, the mirror neurons in the mother's brain are such that the child's brain seems to be hardwired to the mother's, and a lot of interaction occurs that affects them in some way. And then it sets up kind of a domino effect where sequential developmental events then affect the child, like going to school, the peers, teachers, and so on. And all those sequential developmental factors result in what we see as adult attachment. So more and more we don't ask what the cause of an intimacy disorder, we ask about what are the developmental pathways that might result in one pattern versus another pattern. And therefore, what can we do as therapists to identify where the injury is in order to be able to repair it? And so I'm one of these therapists who strongly believes that we have to know the developmental pathway to the adult psychopathology in order to be able to treat it. And, psychiatry has been pretty much oriented towards more of a disease model of identifying the DSM and treating it through medication. I think psychology has been much more oriented towards developmental psychopathology and looking at these pathways and how they result in what we're going to finally call an intimacy disorder, and at the same time to begin to be able to ask how to repair that. And so my emphasis today is going to be repair of the attachment system and repair of this in some way. So that's where I want to start. I guess we got to ask ourselves, what is intimacy? And intimacy is somehow where two people get together and you feel like that person gets you, they have your back, they're there for you, they're empathetically related, so your well-being is as important to them as their own. They're compassionate, they can tune into you in some way, they praise you, they listen to your problems, they try to make you happy, they support your dreams, They cheer you up when you're sad. They're there when you're sick. They share the most innermost feelings with you. They bring out the best in you. And when you're in a healthy relationship and there's true intimacy, you become the person that you're meant to be. So as we look at the components of what I just said, then the pieces that seem to be important is that there needs to be a self of the individual, and then there needs to be attachment between that individual and another individual, and so two selves come together. And what we've seen in preoccupied attachment is that two people can become a mesh, two halves make a whole, and you get a fairly unhealthy relationship. And we see that as a boundary disturbance in some way. So clearly, one component of repairing the attachment system has to be the development of the self. What is it that goes into a cohesive sense of self? And I think that's where Mary Main came in. Mary Main really recognized that one of the elements that seem to occur among the children who've had early attachment deficits was this problem of having a sense of a cohesive, coherent sense of self. And Dan Siegel has written a lot about Mary Main's work and has elucidated this a good bit also. And so the point is that when you have avoidant attachment, you are suffocating. We need love like we need oxygen. And we need to connect to other people. We're a troop species. We're, as mammals, we run in troops. And when we find that the person who we attach to early in life is also the person who we're most afraid of, then Mary Main helped us understand what was called disorganized attachment. With disorganized attachment, it seemed to be different than the avoidant pattern, which was, under stress you move away, the preoccupied pattern where you tend to move towards, but there was this strange kind of thing that almost looked phenotypically dissociative, where the child would approach the mother and then stop suddenly and look at the ceiling, or start to bang their head against the wall, or something of that sort. And Mary Main described these, particularly around abused children and children from poverty samples, as the disorganized pattern. Patricia Crittenden, following Mary Ainsworth, called this the AC pattern. An AC pattern is more understandable than disorganized, and has elements of the A and elements of the C. And Patricia began to classify that in some way. So this gives us a hint as beginning to think about what is an intimacy disorder. It has something to do with approach and avoidance. And in my practice, particularly with addicts, what I see are individuals who are quite avoidant. They're afraid of true intimate connection. They've probably never had one. Even when they have sex, it feels very mechanical and quite dissociated. And at the same time, it's because they were neglected a lot in childhood, they don't have a lot of the natural abilities to form healthy relationships. And so they also are starving for love, and they cling and then they get scared and they pull back, and they're looking for a buffer. Now, that buffer can be a fantasy pattern where they fantasize another person to create distance. It can be a fantasy pattern of internet pornography, and that creates distance in some way. Or they can use an eating disorder, for example, numbing through anorexia or bulimia or binge eating, in order to be able to insulate themselves so they can't get too connected or close. And so they modulate themselves between closeness and distance by using their addictive behavior. Chemical dependency and such are the same thing. So often in the literature you see people who give up alcohol and drugs discovering that they're alone. And so the genius of 12-step is that you're beginning to have people get together 3 times a week to connect in some way. And as they connect, then what happens is they are able to have some intimacy because they feel like here are people who understand them. There are people who have their back, people who know them, their own tribe, and other people out there don't seem to get it. And so the genius in that is that we all need some sort of community in order to be able to heal, and the 12-step community is what's most helpful in the healing environment. Now, people who don't use the 12-step community then oftentimes feel totally alone without their addiction, and therefore they're very at high risk for relapse. And so where I've come from most lately is, I've run treatment programs, residential treatment programs for chemical dependency and for eating disorders and then for trauma. And I found that we did incredibly good work, and what we did was necessary but rarely sufficient. Too many people were relapsing, and what we were doing was useful, but so many people, when they left, continue to have chronic disorder. So, we can take post-traumatic stress and resolve the trauma successfully on, a PTSD scale, or we can take depression and resolve depression on a Beck inventory. We can even resolve anxiety on an anxiety inventory. But I don't want to ever get the illusion that that's treating somebody effectively. I think that we can, obsessive compulsive disorder, use the Y box, and the person, when they come in, they'll have obsessive compulsive, when they leave they don't, and you feel really good about yourself. But I've never felt really good about myself because I think that those are necessary but not sufficient. And so I've gone back to the drawing board and I've said, what is missing from this equation, because people still seem to be miserable. And so my focus these days was to open up what we have now here in Monterey, which is an IOP PHP program, Intensive Outpatient Partial Hospitalization Program. And in that, what we're trying to be able to do is work with the next phase. Once a person gets under control of the symptom, then how do we begin to create a life worth living? And so what I've begun to do is to really work on this intimacy and intimacy disorder and help people begin to form secure attachments. Now, to do that, we end up using life coaches because so many people didn't have the structural abilities to be able to form close relationships with either themselves or others. So that's sort of where we've been heading, and really principally what I want to share with you today. The basic idea is that love and compulsion cannot coexist, because love is the willingness to be affected by another human being, to allow yourself to get connected. Compulsion is we wrap ourselves around an activity, a substance, even a person to survive. And so we get people who are addicted to people, either mothers, or fathers, or lovers, and they get addicted to that person. And to me, that's compulsion. So love and compulsion can't exist. Compulsion is a state of isolation. Love is a state of expanding. So if you're in a relationship with strong dependency needs, you have anxious attachment, you have preoccupied attachment, you have an intimacy disorder. If you have a relationship with two strong individuals who are continually enjoying each other's company, and one supports the other's autonomy, independence, and capacity to connect, then you have a secure attachment. Now, in the marital therapy work that I did with Masters and Johnson, we did all this wonderful work with people who were couples. And we would work with them on communication skills, and we would work with them on problem solving. We work with them on sharing each other's dreams. A lot of what Gottman talks about in his book, The Marriage Contract. And Gottman was a genius, the two of them, in their ability to be able to help us with a couple. But again, I was very dissatisfied with my work at Masters and Johnson and with Gottman's work, because what I found was that you can teach people how to live in the same space like roommates in a compatible way as friends. But the problem is that you have to have an I before you have a we. And so many of these people were filled with so much self-hatred that they found themselves constantly pushing away. And so the more the other person would attempt to be kind and loving towards them, the more scary it would be in some way. And so my focus has been on what I call intrapsychic intimacy as opposed to interpsychic intimacy. Interpsychic intimacy is that what goes on between two people. Intrapsychic intimacy is one's ability to form a secure attachment with self. Now, I would say that almost 100% of the clients that I talk to will tell me that they hate themselves, that they feel like they're bad, they feel like they're injured for life, they feel like, that they've got some sort of chronic disability. And, in the early days when I was younger, I'd try to mirror them like in a Winnicottian sense of holding up the mirror as a therapist and forming a attachment as their therapist. And as I became sort of a good enough mother and mirrored back to them that no, they weren't bad, that they were loving and they were caring. And, I use so much of the cognitive therapy literature of having them question their irrational belief systems and having them, do Beck and other kinds of challenging of their thought systems as cognitive behavioral therapy became popular. And again, I found that although this helps some, just like ego strengthening does and positive affirmations, it really didn't change the schema that were embedded in the brain. And I ran into Jeffrey Young along the way, and he said, I worked in Beck's laboratory, and I found that cognitive therapy really doesn't work with people with personality disorders. And all my patients had personality disorders. And I thought, yeah, I get it. That's exactly what I find. And so these cognitive therapies are useful and necessary, and again, can change people's responses on question and answers, but the schema stay, the core beliefs that are in the hard drive stay basically the same. So we came into this new age of therapy, and there was this belief system over the last 10 years that to change these core schema, Jeffrey Young called it schema therapy. And to do this, we had to go into the affective system because in a very simplistic way, these are, the first couple of years of life when you feel like you're bad because your mom slaps you across the face because you're supposedly behaving in a way that's undesirable, then you feel like you're a bad child, and that gets written into these limbic structures in a kind of indelible sort of way, and it's hard to be able to turn away. So the first stage of working with an attachment disorder is to find some way to change these core schema so the person has intrapsychic intimacy. They like themselves, they feel lovable, and they feel like any person who gets in a relationship with them would be very, very lucky because they're such a unique, extraordinary human being. Now to do that, schema therapy was one of the tools that began to work. Another one was I ran into Dick Schwartz and his internal family systems model, and I invited him to work with us for about a year, and I actually sat in and did sessions with him for a year, and it was an ingenious model of beginning to look at these dissociative states within the individual's mind where they can believe that they're a good person and a bad person at the same time. Now this was really important to me because in my early work with, for example, priests, I had done this work with priests who were molesting. I think I had about 20 of them in therapy at a time. And they were doing really good things, and they would help people get married, they would help people heal when they were hurting 24/7, and they would do these bad things where they would molest children. And you'd wonder how the person could do both things simultaneously and have any coherency. And the answer is they didn't. These were the people with disorganized attachment. Disorganized attachment leads to dissociative internal systems. And so good people do bad things. And when that happens, they categorize them into, files inside their brain, and they're able to do this at this hour, and they're able to do this at this hour, and they can coexist in some way. So when you have these dissociative states where you're able to be able to believe two things that are contradictory at the same time, you have what Dick Schwartz called polarized parts. So part of you can believe you're good, and part of you can believe you're bad. Part of you can believe you're smart, part of you can believe you're stupid. Part of you can believe that you can help people, and another part of you can feel like you're selfish and narcissistic. So we have this capacity not only to believe two things, but many things at the same time. And in order to be able to take that disorganized state and develop some coherency, there needs to be internal integration. And so the first stage in healing attachment is always to take these internal states that lack cohesiveness and coherency and begin to integrate them. And that was the genius of Mary Main. She recognized that when people had narratives that they talked about in their life, that you could pick up in the way they used language, these contradictory, lack of integrated narratives. And that's what she called disorganized attachment. Now, this was really helpful because in the adult attachment interview, you could give somebody an hour-and-a-half test, and you could then put them in a category called disorganized attachment or avoidant or preoccupied in this adult attachment interview, and it highly correlated with the early attachment literature. And then you could begin to help them move to what was called earned secure attachment. So I went off and I got trained by Mary Main and her co-workers in this adult attachment interview, because I wanted to learn how you take a person with disorganized attachment and how they get to the point of called earned secure. And so I studied this earned secure pattern and began to look at how that happens. We have to have some way of healing, or we're not doomed in the first few years of life by the things that are done to us. Things happen to us in our development. Our brains are, there's plasticity and resiliency, and many of us heal ourselves. And therapy certainly is one of those healing agents. Now, what happens then that takes a person with disorganized attachment and moves them towards earned secure attachment? If we could begin to articulate that, then therapists could then have this new kind of therapy that would be oriented towards taking a person with an attachment disorder and help them begin to move to secure attachment. And I believe that that's the key to working with couples. I think it's the key to working with addicts, and I think it's the key to working with trauma. That there was a missing piece. And so I went around the country and I went to people's workshops and I said, you know, Diana Fosha, or I went to Bessel van der Kolk, or, you know, I went to Schwartz, and I went to Daniel Siegel, and many of you have done the same thing. I went to hear Mary Main, and with each of them I struggled to hear what they were doing to help people move to earned secure attachment. I must say that the field has not emerged in a very major sort of way. There's not been any empirical studies to show that people actually change. So I started doing pre-tests and post-tests. I gave the adult attachment interview when people came in. I gave it to them when they left. And I wanted to demonstrate that the key to treating addiction was helping them move towards earned secure attachment. I did a certain small sample of that and found out that indeed we could change people's attachment scores, and I'm going to lay out some of the techniques to be able to do that, but this needs to be empirically established to a much greater degree. Now, I've talked about attachment and I've talked about the development of self. The thing I have not mentioned, which is really important, is affect. That one of the things that people found when they looked at secure attachment was that affect was an important piece of this, and Strofe was one of the first ones to really publish this idea that affect regulation is a key piece to this. And so not only is the development of self really critical, not only is the ability to attach and form healthy attachments, but also there needs to be some sort of affect tolerance, distress tolerance, and ability to be able to express affect in a reasonable sort of way. People with avoidant attachment are all in their head. They think everything, but they can't feel it. They act like they're empathetic, but they can't feel it. Sometimes I get this with cognitive behavioral therapists. They're so busy with the techniques inside their head that they're not really feeling true compassion and empathy. I remember when I started working with Dick Schwartz, I would find that the part of me that went into therapy was the scientist. And as the scientist went into therapy, I'd be thinking in my head all these things empirically and trying to do interventions in that way, because that's the way I've been taught as a psychologist. I think part of what Dick taught me was I had to get my scientist part to step back and to get my healer inside to be able to step forward, and that what I needed was to be with the client, and that all my thinking in my head was keeping me from truly bonding and connecting with the client. And so I would work on getting my empirical parts to step back, and I would try really hard to bring my healing, my real self in. And my relationships with my clients got deeper and stronger, and that turned out to be one of the major elements of change in the relationship. So, I want to emphasize that the more the therapist does their own work, the more they have their own secure attachment with self and others, and the more they allow their affect and their capacity for affect and empathy and compassion to be able to flow between them and the client. Oftentimes it's the first healing energy the client has ever received in order to be able to begin to mend the damage in some way. And I found that probably more important than anything that I learned empirically. So, most of you have that natural capacity and it works for you, but sometimes learning, new techniques can get in the way of that. And you want to be able to put the techniques in the back and let them guide the real self entering the therapy room in some way. Okay, now moving on a bit, these rules of attachment are really rules that people live by. And so the schema that I'm talking about, most of you are probably aware of: trust, power, control, esteem, intimacy. Trust, power, control, esteem, intimacy. And when your parents, who are both nurturing you and then you're terrified of because they're cruel and beat you, or something in between that, then what happens is you don't trust anybody, you feel like you're a bad person, you feel like you lack internal control, so why bother even trying? You feel a sense of powerlessness, and you're terrified of closeness with people, and so you tend to move away when people move towards. And all those core schema need altering in some way. And they're based upon the first 10 years of your life or the first 20 years of your life, it may be. But then people tend to repeat these patterns over and over again. They pick partners that hurt them, and then it cements what they learned in these early years. And so it just becomes, like a vicious cycle. So what you want to be able to do is to begin to help people begin to see these patterns, classify them, let them see more about the attachment patterns that get set early in life, and to be able to do that. In my early work with eating disorder clients, we gave them all the adult attachment interview, and almost every client we saw had what Patricia Crittenden called an AC pattern. They were both avoidant and anxious simultaneously. And in comparison to all other psychiatric patients that were compared to this sample, eating disorder patients had much greater incidence of AC pattern than the others. So what must happen is that at the same time they feel like they need to move closer, they feel the energy to move away, and it makes them feel crazy. And so they need some way to be able to modulate those opposite kinds of feelings. And so what we want to begin to do is look at that somehow. And the result of that disorganized attachment was what I call a black hole. There was like a black hole in the middle of their stomach, and no matter what they got, they needed more. And so the addictive personality, which so often comes from disorganized attachment, internal dissociation, and PTSD trauma, that pattern presents this emptiness inside, that this unquenchable thirst, this hunger. And so they get the feeling, the illusion of control, some feeling of cohesiveness when they're using in some way. And I can't explain why that happens. I just know that they feel some instant relief, and it feels so horrible to get that empty feeling that they'll do anything to escape it in some way. So addiction is sort of the result of that. And so in order to be able to understand addiction, you have to understand this addictive personality. And the addictive personality that I'm talking about is due to internal contradictory working models, as Bowlby called it, or dissociative states that lack cohesiveness. And the person feels like they're bad and good at the same time. They feel like they deserve to be loved, and they feel like no one's going to love them at the same time. Early in the work with adult children of alcoholics, Schwartz noticed that there were these contradictory internal belief systems, internal working models. I deserve this, I deserve nothing. And everything they believed was polarized with something else. And so much of my work is helping them begin to look at these polarized internal states and be able to, in a gestalt way, to have these parts of self begin to talk to one another. And so I can feel like I'm a bad person, I can feel like I'm a good person. I can feel like I'm a smart person, I can feel like I'm a stupid person. I can feel like I deserve to be loved, I can feel like nobody's going to love me. And what one has to do is access these internal states and then find some way for them to communicate and figure out how to live in the same body. How did I learn to do that? Interesting enough, for 10 years I worked with multiple personality disorder, now called dissociative identity disorder. And that when you're working with dissociative identity disorder, those of you who've done it knows that you've got to get two selves, being able to learn how to talk to one another. And there are always these persecutory parts of self that want to beat the person up, but you find these persecutory parts are what we call failed protectors. And it turns out that all persecutory parts are failed protectors. And so what one has to do is, when you're working with dissociative disorder, is work with the persecutory alter and begin to help it begin to use its energy to help the individual rather than to hurt the individual. And there's a certain art in being able to do that. Well, after 10 years of working with dissociative clients and learning how to be able to do that, it became really obvious to me that all of us have persecutory parts, and these are all always failed protectors. And the key is being able to use the energy from these failed protectors or persecutory parts to really help the person and truly protect them, as opposed to what they're caught in, which is being a failed protector. And so in these polarized parts, so much of what I'm doing is I'm taking the part that hates the individual. So, I'll get a client, let's say, who's obese and has binge eating disorder, and they say, I'll say to the part, if I can access the part in my office, I'll say, so tell me a little bit about yourself. And that part will say something about its history. And then I'll say, what are you afraid will happen if you lose the weight or if you stop binging? And the person says, I'm afraid I'll die. Or I'm afraid I'll be alone. And what if you weren't going to die, and what if you weren't going to be alone, is what Dick Schwartz would ask them. And when you would ask that question, you would begin to get into the system and understand the function and the purpose of the symptom. And only by understanding the function and the purpose of the symptom and how it made logic with regards to the development of the individual could you begin to unwind it and be able to say, well, what if I could help you live and I could help you not be alone, and you didn't have to binge? Would you be willing to give up the binge then? And the part would say, I don't believe you can do that, but if you can, I'm open to it. And so you would get these parts working cooperatively and collaboratively and give them new job descriptions, and you can actually work with schema and do state-dependent learning and see really big changes in the belief systems and the way the schemas operate. I mean, I cannot tell you enough stories of how I've done this, and I've had anorexic clients who wouldn't eat for 3 or 4 days, so, come out of a session and say, I'm hungry, I'm going to go eat a sandwich, and go over and eat a full meal, to my disbelief. And I've had binge eaters who literally will stop eating, they're binging, who've been to 3 other therapists, and they've been recalcitrant with regards to their relapse. So you see these incredible changes in people in short periods of time when you begin to do this work. I always feel, as an empiricist, that every client and every session is an experiment. And if what you're doing is effective, then you see change. And if it's not effective, then you don't. So, you begin to see that these modalities are highly effective. And so these protective parts then help the individual. Okay, now I want to turn now, I've been talking mostly about being able to work with these internal states that are dissociated and disorganized because of the early attachment difficulties. And what I've said is that as these parts begin to integrate and they begin to have able to access some of the emotions and feelings, then we have the beginning of self-compassion. Self-compassion is where you can begin to grieve the losses of your childhood and be aware of how you've been injured and hurt, and allow yourself to feel sad for yourself. That's different than depression. So most of my clients get sad, but there's not a neurovegetative component to it. There's a grieving piece to all good therapy. And so they're grieving the losses of their childhood. They can begin to feel empathy for themselves. Some of that is sometimes called inner child work, and people don't like that because it sounds very, kind of rinky-dink. But the truth is, self-compassion and self-empathy is anything but rinky-dink. And being able to have people feel true compassion for themselves is really critical, and is a requisite for being able to feel it for others. When you can experience your own suffering and feel the pain of your own suffering, that is when you can really begin to allow yourself to feel other people's suffering. It takes one to know one, and you become part of their tribe. And when you can become part of their tribe, then you can begin to help them heal in some way. That's why recovering people sometimes are much better therapists with other recovering people, because they get each other at some deep sort of level that a non-recovering person sometimes is unable to do. So then self-empathy is necessary, and then how does self develop? Well, I used to think, well, what we'll do is we'll teach the person to have a sense of self. That what we'll do is we'll help them begin to interview other people and let them in a cognitive behavioral way see how themselves, how other people see them. The problem with that is that they present an imposter or false self. So what other people see is the false self. And the question is, how can you access the true self and help the person begin to be mirrored for their true self? Now, Dick Schwartz suggested an answer to that I never would have believed had I not seen it myself in therapy, and that is that he suggests that the real self is there in all people, but it gets covered over with protective parts, and those protective parts become the false self. And so you start telling people what you think they want to hear, and that's protective, because so many clients who are raised in a family of conditional love develop what we call otherization. They're highly reactive to telling other people what they want to hear. And trauma survivors are so sensitive that they can tell what the other person needs to hear and tell them that. And they get so good at it that there literally is zero self left, that they're constantly reacting to what they think the other person wants in some way. That's very much preoccupied attachment. And so what we need to do is get them away from those people and help them have enough time with themselves that they can begin to ask themselves, what do I think? What do I feel? What do I want? And then feel entitled to be able to ask for that and act on it in some way. And as that happens, the person begins to get, the self begins to differentiate. The self was always there. It was always sort of covered over by darkness. And as the darkness pushes itself back, the sun begins to shine. The self was always shining. Something got in the way, kept it from shining in some way. And so what we're trying to be able to do is help there to be a greater differentiation of the self system so the person becomes who they were meant to be. And in that, there's a self-parenting component. The self-parenting is that the person begins to take care of themselves. So I'll say to the addict something like this. Every time you binge and you eat 3 meals, you're taking that little child and you're filling it with food and telling it to shut up. And that part begins to get treated by you the same way they were treated by their caretakers. And for this part to begin to trust you, you're going to need to focus on self-care. And self-care means not injuring oneself. Tell the heroin addict, if every time you do heroin, you're taking that lost, lonely little boy and you're hurting him one more time. And what you need more than anything in recovery is a commitment to self-care. And so what we're going to do is we're going to map out self-care. So what I would say is that the first 2 components of treatment, the first one is beginning to develop a narrative of one's life where there's some cohesion and cohesiveness to it. And I usually have them basically lay out a sheet of paper and begin to lay all the events and thoughts and feelings of their life and pull it together and talk about it in group or individual. And then the second component is developing a plan for self-care, eating, sleeping, exercising, not hurting oneself, and getting under control of addictive behavior, and making a commitment every hour of every day to self-love. And any spiritual piece to this that you can add that's within the value system of the individual is going to help enormously to be able to do that. So that would be the second component of treatment. Then the third is to be protective and to be able to do whatever's necessary to help the individual begin to grow. And so the key element of that is to begin to look at perfectionism. Perfectionism is the enemy of self-care. In perfectionism, no matter what you do, if it's not perfect, you beat the shit out of yourself. And as long as you're doing that, it feeds the self-hatred. And so more and more there's a commitment to every time you say something that's self-punitive, you need to write that down and challenge it. That's where the cognitive therapy model comes in. And as you get these punitive parts, you begin to talk to them in therapy, and you begin to help them understand how they came to feel this way about themselves and what the truth is. And you begin to challenge them, have them challenge themselves into these irrational beliefs. What's the evidence for this? What's the evidence against this? There, cognitive therapy principles work really well, but they work with dissociative parts, helping them begin to understand that the way they came to believe in themselves is reasonable based upon the events that occurred in their life, but were never reasonable in the sense that the parenting they got was oftentimes punitive, punishing, and led to disorganized attachment patterns. So this insight is really necessary. So we're getting a capacity to experience more feelings. You're getting a sense of acting on the world with some greater sense of entitlement and mastery. We get greater self-esteem, greater questioning of self-injury. We learn to soothe painful feelings and be able to ask for help from others. To be able to turn to others for comfort and soothing, we use groups, and they can talk about their pain, and groups give them lots of love, and they give lots of love back. And then we get them to be able to get out and do things. We use our life coaches to be able to do that, because the principal pattern of a trauma survivor and an addict is avoidance. And they use everything they can to avoid. So our life coaches get them out there looking at everything they're avoiding and everything they're refusing to do and getting them to do it today. But to get him to do it not alone. If you have a child who's afraid to get on a plane, you don't say, get your ass on that plane. What you do is you say, I'll get on the plane with you. We'll hold each other's hand. I'm afraid too, and we'll do it together. And that's the philosophy of a life coach. No wonder this is scary for you. You don't know how to be able to do this. So something as simple as dating. There's a lot of skill that goes into dating. There are things that happen when you're 15, 16, 17, 18, 19, 20 years old that are part of trial and error. And if you haven't learned those things, it's hard to be perfect. Sexuality, God, most people don't know how to make love, even after they've done it for 15 years. And there's a lot of skill in making love to another human being, particularly if it can't be touched. There's an interesting story, which is that some of the attachment researchers studied avoidant attachment. And they looked at teenage girls who had avoidant attachment. And what they found was that they had sex with securely attached girls with the boys. But when they had sex, 1, it wasn't pleasurable. 2, they didn't feel anything. They felt numb. And 3, they didn't like it. They just did it because they wanted to keep up with the other kids. Now, that makes a lot of sense if you think of avoidant attachment. Now, imagine now you're 30 years old, you have avoidant attachment, and you've been pushing yourself to have sex even though you don't like it, don't enjoy it, and you don't feel anything. There you develop what's called an aversion reflex, where you become almost phobic of it, and it feels like you're being molested or raped even though you're giving consent. And some of these people have enormous trauma because even though they're giving consent, and it looks a lot like a sexual abuse survivor even when they've given consent in some ways. And so you see that they react much like post-traumatic stress disorder. So a lot of the work I did with Masters and Johnson treating sexual aversion turned out to be incredibly helpful in working with these individuals because there's a phobic element. Now use that model and think about all the other things that, going to college, getting a job, doing a job interview, writing up a resume. All these things have tremendous complexity. In this day and age, our culture has become so complex that a lot of people don't know how to do it. And if they don't have friends that they can turn to teach them how, they end up, A, not being able to do it, B, avoiding it, and then 3, they get highly perfectionistic, and if they can't do it right or they can't do it perfect, it's not doing it all. And no one ever taught them that it's reasonable to make mistakes, and that the only way people can learn is make mistakes, and we all make mistakes almost every day of our lives. And if we can learn from those mistakes, we're wise, but if we beat ourselves up and call ourselves stupid, we're not. And so being able to teach people how to profit from that turns out to be part of the recovery map. So the result of this is that people begin to internalize a greater sense of affect regulation, a sense of power, mastery, control, esteem. And every time they do something, they feel good about it, and they felt security. The problem, it seems to me, is that as so much of the literature is coming out, that early trauma and early attachment deficits result in changes in the central nervous system. And so, as most of you probably know, there are changes in the downregulation of cortisol, and most of the neurotransmitter systems are highly dysregulated. And so what goes with this are changes in brain pathways and even neuron firing, as Dan Siegel's talking about. And so the problem with so much of this is that even to get started doing this, there are these huge deficits in affect regulation. So if you have a bipolar individual who have these ups and downs, they're going to have repeated negative experiences, which is going to result in greater avoidance. And so probably the miracle of our modern age is the new medications that are available. And so many of these medications are absolutely essential in the work we're doing. I know I couldn't do 50% of what I do in psychotherapy if these medications weren't available. The mistake that psychiatry makes is that these medications are the treatment. These medications are not the treatment. These medications allow the person to benefit from psychotherapy and allow them to be able to have masterful new experiences and to lay down new brain pathways. And we have to get away from this idea that it's either or. You know, all my clients are on some medication typically, and those medications then allow me to be able to have enough affect regulation and enough control over out of control behavior and get them out of their bedrooms where they're massively depressed and help them get under control of their addictive behavior sufficiently for me to come in and help them understand the purpose and function of their symptoms and to begin to develop new patterns of behaving on a day-by-day basis that then allow them to give up the medications in time. And that needs to be the integrative model we can think of. There's too much arguing on what, you know, cognitive behavioral therapy, medication therapy, you know, this therapy, that therapy. I think the more tools you have, the more people you can help. And there's so many treatment failures these days that you can't have enough tools to be able to help an individual. So now let's then get down to avoidant attachment. Avoidance of attachment in your clinical case will be a person who has difficulty getting close. They oftentimes have difficulty feeling anything. They mistrust individuals. They're fearful of closeness. They present a false self. And when you work with addicts like I do, they are committed to maintaining their binge eating. They're committed to their obsessive compulsive patterns. They're committed to their self-destructive self-injury. And they drive you crazy because you're doing everything possible to help them get rid of their symptoms. They're in your office to get rid of their symptoms, but they don't follow their treatment plans, and they're highly, they relapse with high frequency. And so you oftentimes feel like a crappy therapist because they're recalcitrant addicts. When you have a recalcitrant addict, it's not that you're a crappy therapist. It's not that they're a bad patient. The issue is always that what you're dealing with is that they need to have that symptom. It functions for them to maintain their avoidance. And the key thing is to focus on the avoidant attachment, but not focus on the addictive symptom. You have to get relative control. They have to not binge and purge every day 6 times. They need to get under relative control of the symptom. Then once they're able to do that, then one has to deal with the avoidant attachment. And to do that, you can't just do it in your office. You know, I've tried teaching them feelings and vocabulary of feelings. I've tried doing expressive therapies where we can begin to get them to act as if and be able to express those emotions. But it's taking a look at the things they're avoiding in their life and getting to do the things they're avoiding. It's time to start dating. It's time to start sharing intimately. It's time for you to be able to self-disclose. It's time for you. So every week I give them behavioral assignments that they need to take a risk in a systematic desensitization way, 1 step beyond their comfort level, but not 2 steps beyond their comfort level, baby steps, to begin to try on some of these new behavior. But so many of times you don't even know what they don't know because they can't tell you. So being able to see them in the real world, talking to their families, talking to their spouses, talking to their brothers and sisters. I'm a systemic family therapist. I love bringing in other people because I get another picture of the individual. And so only by bringing in the relevant others do I get a full picture of what this person's truly avoiding. And I'll bring in their kids, I'll bring in their grandparents, I'll bring in anybody who will talk to me, or I'll talk to them on the phone, because I need to get a full systemic picture of this person and how they interact in their world. And then they're oftentimes not going to tell me because they don't know what they don't know. As we're confronting so many of these things, the person begins to move away from the false self and begins to move more in the other way. The person with the preoccupied attachment has excessive worry about relationships. They're going to come in every single time talking about what their partner did or didn't do. They're looking for approval at all times. They are obsessed with the partner. They're addicted to the partner. They're jealous of their partner. They are constantly going and whining amazing kinds of ways, and they want to fill up their sessions with all the pain of that. And you have to stop it and be able to have the person have a period of time where their primary relationship is with themselves. And sobriety. Sobriety means that you begin to have a primary relationship with yourself, and that's requisite before you can have a relationship with others. I know there's nothing new in that idea, but it's always argumentative because the client with preoccupied attachment won't listen to you, and they're going to run out and get into a new relationship, but they won't tell you about it. They'll run out and have sex and not tell you about it because they know you don't want to hear it. But you have to convince them that having a relationship with yourself is a requisite, and that's where you do all the work with boundaries. Teaching them healthy boundaries and being able to know the difference between healthy and unhealthy boundaries is something you can teach a person with cognitive behavioral therapy in some ways. All right, now next is working with these narratives. I like for the person to tell their story, and I have a group which is I call narrative storytelling. And what I do is I have people tell their history and begin to put coherency to their story and fill in more and more details and over and over and over again to be able to have a story that has coherency and begins to have a pattern in some way. Now, in the adult attachment interview, you see this interesting pattern where a person will come in and they'll say, tell me a little bit about your relationship with your father growing up. And you say, well, my father and I were very close. And you say, well, give me an example of you and your father being very close. The person will say, well, my father, he taught me how to cook. And each day we would go into the kitchen and he would teach me the right way to put seasoning on food because he was a chef. Now, if you're listening to that carefully, what you notice is that it's nice that his dad taught him how to cook, but that isn't very close. That's an instrumental form of closeness. It's not an emotional form of closeness. Being very close is, I was sick, my dad took off work, came home and held me while I threw up. That's very close. So the person doesn't really know what very close means. And so this person has some sort of attachment disorder. And so what we do in group is we give examples of these kinds of internal attachments and begin to show them what it means when a person says very close. And by doing that, the person can begin to understand that the way they have been interacting with people is oftentimes the way they've been taught by others. And so if you think that being very close is teaching people how to cook, then that's probably how you're going to teach your kids, and that's probably how you're going to be friends with somebody. But that isn't very close, and it's not very intimate. And so a lot of men don't know what intimacy is. They don't have any frame of reference for it. The way they learn to be intimate was oftentimes through their fathers who had no frame of reference of intimacy. So you have to give them the experience of what is healthy intimacy in the group setting in order to be able to know what isn't and what is, and being able to truly affect empathy, feel compassion, and to love another human being. That is intimacy. And one has to have that experience in vivo and then label it and teach a person how to be able to know the difference between true intimacy and false intimacy. And that's when you begin to get earned secure attachment. And another example of this is idealization. Oftentimes people come in groups and they idealize their parent. My mother was the best parent. She was a single parent. She worked 15 hours a day to give us money and to give us food and put clothes on our back. We never saw her, but she was a saint. And when we did see her, she was always baking. Okay. Now, is that very close? Is that very intimate? No. That's a mother who works very hard, and I can respect that enormously, but it's not what children require. What children require is someone who has their back, someone who's present, someone who sees them, someone who mirrors them, someone who helps them understand how to navigate themselves in the world. And a mother who's working 15 hours a day simply can't do that. And so it's okay that they recognize, my mother loved me, I loved my mother, she worked very hard, and she cared for us a great deal, but she wasn't there. Now that is secure attachment. Now, that sounds peculiar to you. Why is that secure attachment? There's no warm and cuddly stuff there. What makes it secure attachment is the narrative. The person recognizes that the mother worked 15 hours a day and wasn't warm and cuddly. and is open to learning how to become warm and cuddly in an intimate way, but knows they didn't get that from their mom. And when they didn't get that from their mom, then they're open for developing secure attachment. Idealization is one of the major patterns of avoidant attachment, and it's also one of the patterns of preoccupied attachment, and therefore is one of the major patterns of disorganized attachment. And so one has to begin to deal with that in certain ways. Now, I want to next sort of talk a little bit about breaking this down. Patricia Crittenden decided that these three patterns of just A and C weren't sufficient. And so what she began to do was she began to break them down. And what she noticed was securely attached, avoidantly attached, and preoccupied attached. Each of them had three sub-patterns. And for the securely attached, there was the reserved secure, there was the comfortable secure, and there was a reactive secure. For the avoidant attached, there was socially facile but inhibited, they were compulsively caregiving, and compulsively promiscuous. And then under the preoccupied, there was this punitive, seductive, there was an aggressive form of it, and a threatening one. So when she broke this down, that there were three subtypes of secure, avoidant, and preoccupied attachment, she then began to develop a Y classification system. Now, I know I just went through that very quickly and none of you could follow it, so bear with me. The point I want to make is not that you get down to, you can read Patricia's work herself, but as we begin to understand that these patterns are not sufficient in and of themselves, that an intimacy disorder is usually that a person has a little bit of an AC. And so they can be a little bit of an A and a little bit of a C. They can be an A2 and a C5. They can be an A1 and a C2. So they have a little bit of each of these subpatterns. And so suddenly we have lots of subpatterns of intimacy disorder. So in this now we have a way of classifying intimacy disorders, and then we can predict when a client comes in or a couple comes in, whether the client has an AC pattern or a couple has an AC pattern, which subpattern they need and which one they, how to do intervention. So I invite you all to begin to study some of her work. It's been incredibly helpful to me and empirically fits very much to what I see clinically. Most of my clients have AC patterns. They have a little bit of A, they have a little bit of C, and calling them disorganized isn't sufficient. Beginning to look at the subcategorization, do they have A2, C5, do they have B4, A6, something like that. And they can have a little bit of secure attachment, and they can have a little bit of avoidant attachment. And by just calling them disorganized or unclassifiable, it doesn't help us begin to understand the patterns or how to treat them in some ways. So as I've begun to do this, now I'm beginning to get interventions. For somebody who comes in with A3, C3, I can intervene with them a little different than people can with A7, B7. And they're very, very different patterns. They may be similar letters, but they're very different patterns. Let me repeat myself because you probably got confused in that. What I'm saying to you is there are three forms of preoccupied attachment, there's three forms of avoidant attachment, and there's three forms of secure attachment. That gives you 9 patterns. And a person can have a little bit of A, B, and C. And they're highly predictable based upon the adult attachment interview. And once you get a little bit of A, B, and C, you can then describe the person's pattern and describe the intervention that's going to be necessary. And by beginning to classify these with subclassifications like I'm talking about, it's enormously fruitful in letting out, very little psychological testing tell you how to do therapy. I've never found the MMPI very useful in how to do therapy. It's helpful in understanding something about classifying my client, but never that useful in terms of identifying what they actually do with the therapy. By looking at these attachment patterns, it tells me what type of psychotherapy is going to be most useful. For example, let's say a person has an A3. They're compulsively taking care of others. They're very codependent. And let's say they have a C3, C4. They're codependent, but they get furious when the other person doesn't get better and doesn't respond to them and writes them off. Well, there's an A3, C3. So we have a codependent who's also aggressive. So we have to work on their aggressiveness and the cognitions that are based upon their aggressiveness, and we have to work on the false positive affect. a false positive affect, is they're pretending to care about other people, but they don't genuinely care about other people. To genuinely care about other people, they have to move towards an earned secure attachment or a B pattern. So a lot of codependents have a pattern of codependency where they pretend to care about people and they end up hating themselves. And that then lends us to exactly how they need to be treated in some way. Anyway, I hope you get it. And I'll say more about this in future webinars, but I want to just sort of lay this out because for the first time I have a way of classifying people with intimacy disorder and a real way of knowing with the testing how to be able to put them in categories and then what kind of treatment to be able to give them in some way. Okay, so just to summarize, because this is getting fairly long-winded, I want to kind of review what I've said so far. One is that you want to facilitate a coherent, reflective narrative. And to do that, we do oftentimes have a person do a timeline and do a timeline group. Two, we want to neutralize their idealization and their loyalties to their family of origin, quit looking at their past through rose-colored glasses, and accurately label what actually happened in their family of origin and what they remember. Do we get the truth? No. All memory is memory that is remembered through rose-colored glasses. But what we want to do is we want to match up the memory of the events and how the conclusions that they've made. Three is we want to facilitate metacognition. Metacognition I've not talked about, but this has come out of the work from Fonagy and his work then with the Menninger Clinic, and some of the people from Menninger Clinic have written books on metacognitive therapy. Metacognition is thinking about thinking. And if you think about thinking, you're able to say, my mother worked 15 hours a day, she really cared about us, but we weren't very close. And that's metacognition, because you can look at things from an airplane down and see things objectively and accurately, and there's healing in that. Five is you need an attuned relationship with your therapist. You need a therapist who has secure attachment themselves and with others, and who can show real self and real compassion. Six is you need to begin to practice self-soothing, self-care, and how to take care of oneself across situations, and turn to other people when you feel overwhelmed. Seven is you need to do work on your belief systems about yourself and others, and if there's a tremendous amount of self-hate, you have to look at the origins of that self-hate within their dissociative systems and begin to work with the parts of self that are filled with self-hatred and self-punitiveness and perfectionism. Next is that if there's trauma, one has to begin to go back and revisit the trauma and do some trauma resolution and work on affect regulation around that. Next is beginning to do self-parenting and begin to forgive oneself for their own mistakes and begin to work with these injured parts of self and teach them self-nurturing and self-love. Next is being able to set healthy boundaries with others, particularly if you have preoccupied attachment, and deconstruct these attachment patterns that I've been talking about and begin to identify what your pattern is, what your core relational conflict is, and how that manifests itself into an ABC pattern. Finally, one has to begin to have needs, be able to express their needs, and feel entitled to meeting their needs, but not with a narcissistic sense of I deserve too much, but with a reasonable adaptation so that they're not driven out of self-hatred or that they're not driving themselves out of some mission to be able to forgive themselves, but more out of a true affect of self-loving, self-caring, and self-compassion. Well, that's a lot in a short period of time, and so I want to stop now and see if people have some questions. There's a book by Luborsky called Countertransference, and he identifies empirically that there's a correlational pattern that all people have based upon their early life, and he can measure that correlational conflict. And he finds that people take this correlational conflict and they create the same conflicts over and over again with others. They're unconscious. They're internal working models. He brings them into consciousness by telling people what their internal working models are and then observes them afterwards. And what he finds is that the people stop their core relational conflicts. And so what he's showing empirically is if you can teach people what their core relational conflicts are, you can teach them the origins of them, then they bring them into consciousness, the person no longer does them. And I have to say, since I've done that myself, that it's really changed my relationships with people dramatically to understand my core relational conflict. And Liborsky says it's the job of all therapists to help their client identify the core relational conflict. Well, thank you very much. And, I love talking. You can tell that. So as long as people will listen, I'll keep talking. And come visit us in Monterey. Harmony Place, Monterey. It's a beautiful place, and you're welcome out here anytime. Bye-bye.